Afternoon, Dr. Mary team. So how are you? Hope you're doing well.
Yes, I'm well. Thank you.
I hope you're not in Uganda.
No, I'm here in Nairobi.
Good. So good afternoon, ladies and gentlemen. Welcome to today's episode on Ebola preparedness. It's actually a series of 11 days that will run out. In front of the screen is this week's topic. So we're going to start today with introduction and overview of Ebola virus disease. This is basically sensitization workshop for everybody. As we all know, in September, there was an outbreak in Uganda that, of course, after the outbreak, as a neighbor to Uganda, we have to be vigilant and we have to be very much aware on what we need to know about Ebola. They've had several mortalities of up to 55 as of November. And healthcare workers have actually been affected. 7 out of the 19 healthcare workers have actually died. So this is a very, very important discussion. I hope we tune in, we listen in, and we learn more about what Ebola is there a vaccine that we can take, and many, many more questions. So with us today is Dr. Maribeth Maritim. Dr. Maribeth Maritim is very much known to most of our audience, so I don't want to introduce her in details, but she's our ID specialist in University of Nairobi and a consultant physician. Dr. Maribeth, welcome.
Good afternoon, everyone. Thank you, Amina and KNH team for this opportunity to make this presentation. So you have to stop sharing your screen so that I can be able to share my screen. Okay. Okay, just a minute as I... So allow me to turn off my video so that I can conserve the bandwidth to allow smooth presentation. So I'll just turn off my video for this presentation. And today I'm going to talk about the overview of Ebola virus disease and give a brief introduction, which Dr. Amina has already done. So this is a series of presentations that will be facilitated by the Ministry of Health Training Subcommittee, just to give us a sense of what are we doing to prepare. So it's just to sensitize and to lay anxiety, particularly among the healthcare workers, and just to give us a sense of what has happened and how are we preparing for this outbreak. So I have a couple of introductory slides, and then I'll go into the overview. So this is the current outbreak in Uganda. And as Dr. Amina has mentioned, the outbreak in Uganda was confirmed on 20th of September by the Ministry of Health and the WHO Afro office. And the etiological virus is Sudan Ebola virus. And we'll talk about this when we go through the overview. And it began in one of the districts in Uganda. And Mubende is actually in central Uganda, where in the map there, it's in red. So that was really the epicenter, and it began after one case was confirmed. And this is a patient, a 24-year-old male, who presented to the several hospitals and finally ended up at Mubende Regional Hospital and died 5 days after admission. And at that time, tests done to try and identify what was causing his illness eventually confirmed that he had Ebola virus and specifically Sudan Ebola virus. And as per the international health regulations, when you have one case, then you can consider that that's an outbreak and you start looking for additional cases. So since 20th of September, the cases have actually spread to neighboring districts and surrounding districts. And currently there are a total of 9 districts that have been affected. And they're indicated there in the map, where we have neighboring districts like Kasanda and Kegegwa, which already have a number of cases. And the cases have been spreading, some to the western part to Kigadi and Bunyangabu initially. And then some of the cases have even spread eastwards to as far as Jinja, which actually is borders close to Kenya. And that's why we really need to up our preparedness. And the ministry has not been resting. They have actually led preparatory efforts since the outbreak was announced. And Kenya is considered particularly high risk because of the traffic between Uganda and Kenya. And we know that Uganda is landlocked and relies on Kenya, particularly the port of Mombasa, for a lot of their supplies. So the preparation has been ongoing, and we'll see where we are. And this will be sort of become imminent as we go through the 11 series that Dr. Amina has talked about. This is a situation rep. I just found it published in the Afro regional website, and I just clipped it, but it's a bit dated. It's almost a week old, and this was as of 25th of November. And like we've said, there have been a total of 9 districts that have been affected, and the total number of patients are at that time were 141 with 55 deaths. And the recoveries have been many, so there have been more recoveries than the deaths. And there's also a very active process of contact listing and contact tracing and follow-up. And remember, for contacts, we'll talk about this, you have to follow the contacts for a period of 21 days. So the follow-up rate for all the contacts that have been listed has been at 73%. And in terms of healthcare worker infections, it's particularly important to track healthcare worker infections because we know that healthcare workers are particularly at risk, because sometimes when the outbreak is still evolving, people might not know the presentation and might not take adequate precaution to prevent themselves. So we've had a total of 19 healthcare worker infections, of which 7 have died, as Amina has said. But what is important to note, once the outbreak was identified and a lot of efforts were done to protect the healthcare workers, including effective training and provision of PPE. And this has actually resulted in less healthcare worker infection since then. So part of the aim of this webinar is really to sensitize all healthcare workers, because we are at risk. We don't know when that first case is likely to present to a facility. And this presentation can be in both public and private sector facilities. And therefore, it's really important for all of us to be aware and to have an index of suspicion so that we can be able to identify these cases and be able to protect ourselves by donning effective PPE. So I just put this slide here, and I know it will be covered in one of the sessions. We'll have a session on epidemiological surveillance, but I put this because I've just talked about creating awareness. So this is the working case definition for Kenya. So we have different definitions. For a suspected case, we have a definition for a probable case, for confirmed case, and then also for community, because we are practicing what is called community-based surveillance, and the community needs to be aware in which people this needs to be considered, and therefore alert to be initiated. So a suspected case is any person with one or more of the following. So you need a clinical criteria, but also epidemiological linkage where the outbreak is currently happening. So the clinical criteria is acute onset of fever, vomiting, diarrhea, abdominal pain, headache, sore throat, measles-like rash, red eyes, bleeding from openings, and history of travel to Uganda or DRC, or contact with somebody who has been with a person with the above symptoms, within the last 3 weeks. So both of these criteria have to be met for you to evaluate the suspected case further. So you need the clinical criteria and that linkage with where we currently have the outbreak. And what we have to remember, this case definition will evolve once we have introduction of cases within our borders. So we need to be on the lookout for evolution of this case definition, and this will be facilitated by the disease surveillance and the Department of Disease Surveillance and Response. We also have a definition for a probable case, and this is any person who meets the suspected case definition and has an epidemiological link with a confirmed EVD case. So again, this would be the definition of a probable case. A confirmed case is any person meeting the suspected case definition and has a positive laboratory result for either virus antigen detected or viral RNA detected by RT, PCR, or IgM antibodies against ELISA. I've seen someone has raised their hand. We will not be able to take questions as we make the presentation. We'll take the questions at the end. So you can type your question in the chat box, or you can keep your hand up during the presentation, but we'll not be able to take questions as we make the presentation because it will disrupt the presentation. So kindly note your question and we'll take the question at the end. So a confirmed case is any person meeting the suspected case definition and has a positive laboratory result for either virus antigen detected or viral RNA detected by RT-PCR or IgM antibodies against Ebola. So for you to say a confirmed case, they have to have been suspected and then worked up to be confirmed by lab criteria so that they can be a confirmed case. And then community lay case definition is any person with hotness of the body with no response to treatment and has bleeding from openings or any sudden death with a history of bleeding. So this is really important because when surveillance is happening in the community, this can actually be the case definition that is able to identify even introduction of cases when you have unexplained deaths within the community, which are compatible with this particular history. So this is the working case definition. And like I've said, it will evolve with time, depending on if cases are introduced. So I just took some photos just to give us a sense that the national governments and the county governments have been preparing. And these are some of the national documents that have already been developed and been signed off the level of the DG. So we have standard operating procedures that we'll be able to share with all the people who are attending this webinar session. So these SOPs are really to help and provide a procedure for different things that need to be happening, including contact tracing, surveillance, case management, establishment of Ebola treatment units, infection prevention and control, and really outlining what are the requirements and the level of and kind of PPEs that need to be worn at when managing or treating patients in the Ebola treatment units. We also have the optimized supportive care for Ebola virus disease, which is really a document very updated that's looking at clinical management, standard operating procedures that help to improve outcomes of patients. So we know that a lot of care for people who get infected includes supportive care mainly, particularly for Sudan Ebola virus, where we don't have active treatments that have been proven on clinical trials. So we remain with a lot of supportive care, and we'll hear about this tomorrow when we have the session on case management. And then we also have comprehensive guidelines on mental health and psychosocial support during pandemics, because we know that healthcare workers who work in the treatment units, even patients who recover, or even people who lose their loved ones, there is a lot of mental and psychosocial impairments and disturbances. So this is a guideline that is really helping to build capacity for the people who take care and even the survivors of this Ebola outbreak. So these are just some of the documents. I could not include all of them on this slide, but just to let you know that the ministry has been working very hard at developing these documents, and we are now at the phase of dissemination, and that's why we are having these webinars to just make people be aware. There will be there have been some trainings and sensitizations, particularly for county teams, but we've not been able to reach everyone, and we know that we are at a point of heightened preparedness. So that's why we are also having hand in hand with physical training an opportunity to use the virtual platform, which we were able to use successfully during the COVID-19, just to sensitize healthcare workers and reach them so that they are not unprepared because of lack of knowledge. So these are the sessions of the 11 sessions that we'll cover this week, and some of them next week, covering the different aspects. So today's session is really an overview, an introduction, and then tomorrow and this week we'll focus around case management, infection prevention, laboratory aspects, including how to collect the samples, how to transport the samples, and what are the labs that will be analyzing these samples. Then we'll have on Friday mental health and psychosocial support. And then next week, we'll have establishment of Ebola treatment units. We'll also have epidemiological surveillance and contact tracing. We'll talk about rapid response teams, risk communication and community engagement. And I know the risk communication and community engagement team have really developed a lot of resources for the lay community, as well as even for healthcare workers. So this will be an opportunity for them to really share what they've been doing and how the messaging is going out to the community. We'll also talk about water, sanitation, and hygiene services, which are a really key component in terms of EVD response and control. And then we'll talk about safe and dignified burials, because we know that burials can contribute to worsening of an outbreak, especially because the dead bodies still portend a risk for infection. So this is just an outline of what we'll be covering during this series. So we'll move on right away to a quick overview of Ebola virus disease. And really the purpose of this lecture is really to set the tone for a lot of the things that will be discussed in the subsequent sessions, trying to explain the virus and the structure of the virus and the different components within the viral structure that are mediating the different illness, manifestation, the clinical manifestation. And some of these components are really targets for therapeutics and even vaccine candidates. So we'll talk a bit about the virus and transmission and different aspects. So this is what the outline will look at like. Viral structure will reflect on the past outbreaks, just to give us a sense of what are the different viruses, Ebola viruses, that have contributed to the different outbreaks and the case fatality rates arising from the different outbreaks. We'll dive into pathogenesis, and this is really important because we now know more about the pathogenesis. And like we said, a lot of the care is supportive care, and therefore understanding the pathogenesis is really important, because early management of infected persons can improve their outcome, because you're addressing the components of the different pathogenic mechanisms rather than waiting for the patient to progress and trying to help them when they are in the late stage of the illness. We look at the clinical presentation, clinical course, and then focus on the sequelae in survivors. And some of the survivors, one of the things we will talk about is really where the virus hides, even in people who have survived, and the importance of infection prevention to prevent outbreaks that arise from survivors. And then we'll just have a slide or two on treatment and prevention, but this will be covered in greater detail when we have the subsequent sessions. So this is a schema just illustrating the taxonomy and the Ebola virus transmission. So when you look at the Ebola virus, it belongs to a specific kingdom, phylum, class, order, and family. So within the family, it's part of the Filoviridae, and the other virus within this group includes Marburg virus. And then we have the genus Ebola virus. And within this genus, we have different species. Currently, we have a total of 6 species. So we have Bundibugyo virus, which there is a lot of abbreviation that goes with this. And it may be important to know this because sometimes you'll be reading literature that talks about Ebola. So Ebola is specifically Ebola virus that is caused, that was formerly known as Zaire Ebola virus. So that's the current abbreviated form, Ebola. And then Sudan virus, which is the cause of the current outbreak, is SUDV. And then we have Thai forest virus, TAF. So when we look at these viruses, especially the ones at the center that have the orangish color, these are the 4 viruses that have caused human infections and that have been associated with the disease. Then we have on the outer circle, we have the reston virus, abbreviated as RESTV, which to date, there's no human infection. There has been a human infection, but not associated with disease. And then Bombali virus, which was identified in 2018. Currently, no human infections have been recorded, but this virus was isolated in bat species, initially associated in Bombali area in North Sierra Leone, and more recently in 2019, also isolated from bats in Kenya. So we know that the bats in Kenya have Bombali virus, but so far, no human disease has been described related to Bombali Ebola virus. So for the 4 viruses that cause human infection, a lot of the outbreaks have been related to Zaire, which is the Ebola. Most of the infections, as I shall show you subsequently, have been related to Ebola disease, and current vaccines and even therapies that exist have been targeted at Ebola. And we don't have a lot of evidence that even those vaccines and therapeutics can work for the different types. And currently, I know in Uganda, there's a plan to have a clinical trial to test vaccine candidates and other therapeutics that will target the Sudan virus. So just for those of you who like finer detail, the Bundibugyo virus was isolated from Bundibugyo district in Uganda when there was an outbreak in 2002. The Ebola virus, again, was isolated from Zaire when there was an outbreak in 1976, together with the Sudan virus. So there were 2 outbreaks in 1976 related to Ebola virus of the Zaire type and Sudan at that particular time. And then the Thai forest is named after a national park in Ivory Coast. And then Reston is named after Reston in Virginia because there was a primate that the virus was isolated from at that time. And then Bombali, like we said, is named after a place in North Sierra Leone. So we may see an increase in these viruses depending on different isolates. And it therefore means when you have an outbreak, you must go out of your way to identify the species that is causing that outbreak, because it has an impact in terms of availability of therapeutics, and even as we shall see, the potential for the ease of transmission, because we know what we currently know is that Ebola virus, Ebola, is very highly transmissible and has a higher case fatality rate compared to even Sudan virus. In terms of the mode of transmission, it's thought that there is a known natural reservoir in the environment, and therefore contact with infected animals in that environment, particularly in forests and handling animals within the forest, then causes a spillover to a human host. And then once you have the disease in humans, as part of the clinical course and the consequences, the person becomes infectious and is able to mediate a cycle that now leads to direct human-to-human contact transmission, or transmission through contact with body fluids or fomites. So that index person then mediates an outbreak within the close contact, which can then spill over. For example, if they fall sick and they go into a hospital, then you can have now a widespread outbreak beginning at the hospital and then spreading. And then also related to the burial of this index case, especially when the outbreak has not been identified, you can have a lot of contacts that now mediate an outbreak. So this is, again, a schema illustrating what we've talked about. So it's believed that the fruit bats of the Pterocodidae family are the natural host of the Ebola viruses. It is introduced into the human population through close contact with infected animals in their ecosystem. So this can be through the blood of the animals, secretions of those animals, organs, or biological fluids. So most of the index cases would be people who go into the forest, perhaps to hunt these infected animals in that system, and then they get infected, and then they become sick. So interhuman transmission is through direct contact with blood or secretions of that infected person. You also have cases of mother-to-child transmission, and then exposure to objects contaminated with infected secretions, such as needles. And this is just what we've already been talking about. So really, the part of this sensitization is that we already know that we have an outbreak in the human population in our neighboring country. And therefore, what we are trying to mitigate is progression of that outbreak by trying to educate or to sensitize all the healthcare workers because these sick people are likely to present in hospitals, and also to sensitize the communities where these people live, so that when they have a person who meets the case definition that we've already talked about, they can be aware and be able to protect themselves. So the role of healthcare workers cannot really be overemphasized, and infection of healthcare workers is of particular concern. So we know that often healthcare workers get infected when treating suspected or confirmed cases of EVD. They can also get infected through close contact with patients, or when anti-infective precautions are not strictly applied. And we know even in the general community, funeral rites play a major role in transmission. And this can be to relatives and friends of the deceased who are in direct contact with the mortal remains. So affected persons are contagious for as long as the virus remains in their body. So this is one of the things we are trying to prevent. And this is an important component in terms of reducing or controlling an outbreak that has already developed. So it's really important for us to understand the genome and the viral structure. And I know this can be intimidating for many of you who are listening in, but I try to include a lot of detail so that you can understand, because I know that for COVID-19 particularly, understanding the virus helped us even to appreciate how the vaccines were able to be developed within a short time and how they were able to protect us. So the virus has this structure and has different components. So it has the glycoprotein, which is a structure on the surface, and the glycoprotein is important for virus attachment and entry. And in the coronavirus, this would be similar to the spike protein that we used to talk about, and is still part of the structure. So the glycoprotein is an important structure that mediates viral attachment and entry. Then we have, still related to the outer membrane, we have what is called the VP40, which is important for viral assembly and budding. So it's the blue structure close to the glycoprotein. Then on the deeper part of the virus, we have what is called the ribonucleoprotein complex, which is illustrated by the green structure inside the virus. So it's a complex that has the nucleoprotein and some enzymes that are important for the virus to be able to multiply, integrate, multiply, and sort of like make copies of itself. So the structures that are part of the ribonucleoprotein complex include the polymerase, which is illustrated where my arrow is. I hope you can see my arrow. And this polymerase is involved in transcription and regulation of viral genome and mRNA editing. So you don't need to know all that detail, but it's a polymerase that's important in terms of transcription. And then related to it, we also have the viral protein 30, VP30, that initiates Ebola virus transcription. So one of the initial processes of multiplication. We also have VP24, which inhibits the immune system, interferon alpha and beta, interferon gamma. So it's able to impair the immune responses that would be developed by the host in response to the infection. We have VP35, which inhibits interferon gamma signaling by inhibiting activation of different components of the immune system. So VP24 and VP35 are part of the viral structures, but they interfere with the host immune response as a consequence of that infection. And we'll see more about this during the pathogenesis. We have the nucleoprotein, which are indicated as blue at the bottom here. in this flowery structure. And the nucleoprotein are key components of ribonucleoprotein complex, and they would protect the viral DNA, the mRNA, from degradation. So they are protective structures that are able to protect the viral RNA, which is at the center of this complicated structure. So we have the RNA inside, and the nucleoproteins are protecting the RNA inside there. So these are important components of the viral structure. And it's important to note the glycoprotein has actually been a target of vaccines, and the current vaccines that have been developed for Ebola actually target the glycoproteins because they are important in entry and even in terms of viral attachment and entry. So this is really an important target. And then we'll talk about how the other things now contribute to the pathogenesis, because we've seen that some of the viral protein components, 24 and 35, work to inhibit the host immune response that now contribute to a dysfunctional immune response as a consequence of the infection. So there's a structure here that I've not talked about, but it's the genomic RNA. It has the 7 structures, and we've already seen what those structures contribute. So we have the NP part, which will encode for the ribonucleoprotein complex. Then we have the BP35, BP40. Then we have the glycoprotein, which has a 3-in-1 structure. There's a soluble, and then there's also another component, and then the glycoprotein. But just remember, it has the glycoprotein part of the genomic RNA, and then BP30, BP24, and the L, which is the polymerase that encodes the transcription and regulation of the viral genome. So this is just in summary the structure, and it's important to note that understanding the viral structure helps you even when you're trying to think about the different therapies that would be useful, and even the candidates for vaccines that will be spoken about in subsequent sessions. So this is a map that's looking at the various Ebola virus disease outbreaks that have happened to date. And it's important to note that there have been more than 20 outbreaks. There have been more than 20 outbreaks. So majority of these outbreaks have actually occurred in DR Congo, including the first outbreak in 1976. So in 1976, there were 2 concurrent outbreaks, one in Congo and one in Sudan, which is now currently a part of South Sudan. And from this table that is on the right side, it's basically showing the outbreaks, the chronological outbreaks from 1976 at the bottom as you come to the top. So more of the recent outbreaks have not been included in this representation, but they are captured in the map. So in the map, when you're looking at this map, we have the countries that are indicated in red, particularly Democratic Republic of Congo. And then we have also in red, Guinea. So the 2 countries in red are actually where the outbreaks began. And we know that when you have an outbreak, sometimes you can spill over to neighboring countries. So in the case of the previous outbreak, a lot of the outbreaks that have occurred have been confined to DR Congo, but we've had some spillage to Uganda. We also have the outbreak in West Africa. The big outbreak from 2013 to 2016 began in Guinea, but spread to neighboring countries in the region, in West African region, to Liberia, to Senegal, Mali, Sierra Leone, and even some were exported to other countries in the to Western countries like US, because some of their patients were evacuated. We have countries that are indicated in yellow, and these are countries that have had cases because of importation. And then we have countries where EVD outbreak started with small imported cases, and we can see particularly Gabon and Republic of Congo have had outbreaks in various time zones. So what is important to note is that we have had more than 20 outbreaks. The biggest outbreak was the West African outbreak that occurred in 2013 to 2016, and we'll talk more about it shortly. And therefore, even as Uganda is battling their outbreak, we are on the alert because we know that these cases can move to neighboring countries. And the countries that are neighboring Uganda have also heightened their preparedness and in preparation for perhaps cases that will spill over to neighboring countries. So this was just to show you how long the list of the various outbreaks are. And we'll talk more about this in this subsequent slide. So this is a very busy slide, but I'll just take you through it slowly. So this is still the history, and this is divided into two slides. So I have this first slide and another subsequent slide. And this is looking at the outbreaks and the case fatality rates that are attributed to Ebola. So this is the Zaire version, the Ebola. So we have had many outbreaks from 1976 at the bottom there, up to the 2018 outbreak. And we can see majority of these outbreaks due to Ebola have actually occurred in DR Congo, but we've had other outbreaks out of that, Gabon, South Africa, DR Congo being the majority. So there are various variants within the species of Ebola, and they've been typed, and we have one, the Makona variant was the one that caused the outbreak in Guinea that spread to the neighboring countries. And the total number of cases were 28,610. And the total number of deaths were about slightly less than half of that. So 11,380. So the case fatality rate, the last row is actually showing the case fatality rate, which was 40%. And what we know about that outbreak is that there were more deaths at the beginning of the outbreak, and there were less deaths as the epidemic continued, because now there were interventions, some vaccines, clinical trials were done, some therapies were tried, and even as people became aware of what is called the optimized supportive care, then more deaths were prevented as the outbreak continued. But it's also thought that because of the duration of the outbreak, the virus became attenuated in the host, and therefore it was causing less and less severe disease because of that attenuation. And we can see, this is just illustrating the case fatality rate for Ebola, which ranges between 40%, which is from the Makona variant, to 100% or close to 90%. So the case fatality rate is 40 to about 90%, meaning that when you get an infection and 100 people are infected, you're likely to lose between 40 to 90 of those people. So it has a fairly high case fatality rate. This other diagram, again historical, is looking at the two other species that have resulted in fairly big outbreaks. So we have Sudan virus, which is causing the current outbreak in Uganda. And what you can see from a summary of this slide, most of the Sudan virus infections have occurred in Sudan and Uganda. We can see starting in Sudan in 1976, 79, and then 2004. And then in Uganda in 2000, again in 2000, 2011, 2012 again, and then the current outbreak. So it has contributed to a large number of outbreaks. And we can see the case fatality rate, again, ranging anywhere between, on average, about 53%. So about 50% of the people who get infected are likely to die. So compared to the other ones, where the case fatality rate was as high as 90%, we can say that the Sudan virus has a fairly low case fatality rate. And what is currently known, it also has a lower transmissibility compared to Ebola. And then the BBBB, that's the Bundibugyo species, again has caused two main outbreaks, Uganda in 2007, and then Liberia in 2012. Case fatality rate is just about 33%. So about a third of the people who get infected end up dying. So again, what you can say is that the case numbers have been fairly low for the outbreaks caused by Bundibugyo. So again, these are just historical data, and these are from publications that have tried to analyze and do meta-analysis to try and summarize different studies and reports around the different outbreaks at different times. So moving on to Ebola virus disease pathogenesis. And like I said, understanding pathogenesis is really, really important because it helps us to see how the virus enters the body and the clinical consequences of that entry of the body and what it does to the host, so that you can be able to explain the clinical presentation and relate it to the manifestation. So the first step is around viral entry. And what we know about Ebola virus, it cannot penetrate intact skin. However, it can penetrate intact mucous membranes. It can penetrate skin that is injured or has cuts, and this can be microscopic cuts and macroscopic wounds. So do not take a risk and say, I know my skin is intact, I'll handle this patient without any PPE because I know my skin is intact. You're likely to put yourself at risk. So the main mode of entry is through dermal injuries to the skin and any of the components, or via direct contact with mucous membranes. And when you're talking about mucous membranes, you're talking about the mouth, the eyes, and other mucous membranes, like the reproductive parts, like the vagina and the urethra. So those are the mucous membranes we are talking about. And we've had even infections that occur because of infected males who recover and still carry the virus in their semen. They can infect their wives and actually initiate an outbreak. So the viral entry is very, very important. Once the virus enters the body, it targets primarily the macrophages and dendritic cells. These are cells that are found within the body, and they're part of the mononuclear phagocytic system. So we know that dendritic cells are found in the GI tract and even the vaginal mucosa, and we have macrophages that may be found in tissues, but even within the blood, moves around within the blood. So those are the primary targets of Ebola virus. And we know that the body has a lot of macrophages, has a lot of dendritic cells, but that is the primary target. So once the virus enters the body, it infects these two cells. It's able to use the glycoprotein and enter these cells. And what happens is that it starts to multiply within these cells using the host, the components of the cell. It's able to multiply. And these cells, once they're infected, there's migration of these cells to regional lymph nodes. And this continues, the infected cells, when they move to the lymph nodes, then you have production of a lot of virions within the regional lymph nodes. That's the primary part of the replication. After that, you have systemic distribution of the progeny virions and infection of secondary target cells, which occurs in most organs. So there's infection of most of the organs, which include the liver cells, other cells that can be found all over the body because the macrophages are found in many, many places. So when you have this systemic distribution of these progeny virions within the secondary target, this is able to occur because of what we talked about, the viral proteins that suppress the intrinsic immune system, both the innate immunity, the natural immunity, and the adaptive immunity. So the virus is able to switch off or suppress the immune response, and this enables it to be able to spread to many, many organs within the body. So as a consequence of that, you have organ-specific interactions that occur in the gastrointestinal tract, in the liver, in the spleen. And as a consequence of this, you have evidence of markers of organ injury that correlate with clinical manifestations. And I'll show you in a graphic presentation how different organs like the kidney, the muscle, the brain are able to be affected because now of primary effects of the virus. So just remember that the virus is able to move far and wide and replicate in different organs, and therefore cause disease, widespread disease, including even the skin. So it's able to enter the skin. So this is illustrated in this schema where they spread to parenchymal cells, like even the liver cells. There is a high serum virus load. You have cytokine storm and chemokine storm because of the inflammatory markers that are being released. And then as a result of this, then you have liver and other organ damage, and then there's immune dysregulation. So we'll see all this in a schematic manifestation. So this is still another illustration of the same. So you have the virus entering the skin. So we talked about skin that is damaged or intact mucosal surfaces, and it's targeting the macrophages and the dendritic cells. These are able to move to the regional lymph nodes and multiply. So there'll be two events that will be occurring at the same time. One event is that once there's replication within the lymph nodes, Then now there's a secondary replication and spread to other organs within the body, like to the brain, to the liver, to the GI tract, to the spleen and kidney and skeletal muscle. So in these organs where it's spreading to, the virus is able to spread and multiply in these other organs. At the same time, because of the effects of the virus, remember some of the viral proteins were able to cause to affect the immune response. So there's immune system dysregulation that affects both the adaptive immune response, which is mediated by B and T cells, and then we have the innate immune response, again, mediated by things like natural killer cells and dendritic cells. So the consequence of that, the impairment of the immune response, is that there is production of excessive cytokines, and these cytokines contribute to death of lymphocytes. So which again results to, in terms of some of the clinical consequences. So the excess cytokines that are produced together with the multi-organ dysfunction because of multiplication or replication of the virus in the different organs eventually leads to circulatory system collapse, which leads to capillary leakage and third spacing. So there's a lot of fluid that's leaking from the blood vessels to the tissues. There's coagulopathy leading to hemorrhagic manifestation. There's damage to endothelium. There's low blood pressure. So all this circulatory collapse eventually leads to the clinical manifestation that now manifests as Ebola virus disease. And the ultimate manifestation of that would be this patient who's bleeding from various orifices. But remember, this bleeding is a terminal event. You may not be able to see it early in the presentation of the patient. So it's not something that you'd be looking for, because if you're looking for bleeding, you'll miss people who are likely to be infectious or who are likely to progress their illness. So we need to be able to identify patients early by applying the case definition and look out for the stage where they are likely to be. And what we currently know is that if we pick the patients early and we offer them optimized standard of care, we can actually have more patients recovering without them reaching the stage of circulatory system collapse. So this is a terminal stage that we don't want our patients to reach. And even when we'll be looking about the clinical manifestation, if we are looking for these patients who are bleeding to say that they have Ebola, we are likely to miss patients earlier that are likely to be infectious. So we need to always think that the manifestations could be different, and we're looking for signs and symptoms to suggest acute infection and then establish disease, and we'll go through some of this presentation. So these are the phases of infection. We have exposure, and then we have establishment of infection. And the first phase is the incubation period. And for Ebola virus disease, the incubation period is 2 to 21 days. So what that means is that it's a long incubation period. And it means people who are in this incubation period, we need to be able to suspect and be on the lookout, because some of them will develop the symptoms, and once they develop the symptoms, then they're likely to be infectious. So unlike COVID-19, where we had asymptomatic infections in people who are still in the incubating period, most of the people who have Ebola virus disease, the moment they have onset of symptoms, then they are likely, the people who are symptomatic are likely to transmit the infection. So again, the exposure, incubation period, and then onset of symptoms. So once the person has the onset of symptoms, they go through 3 phases. So we have the early phase, we have the peak phase, and then the recovery phase. So the early phase is a time between day 0 and day 7. And this patient has a certain illness that's basically characterized by a generalized inflammatory response. So they have non-specific symptoms like headache, myalgia, sore throat, which characterize the early phase. Then the next phase of illness is what is called the peak phase, and that's from day 7 to day 14. And we'll see what are the clinical manifestations of the peak phase. But just to summarize, this would be manifestations that really mirror organ involvement. So you'll have renal failure manifesting there. They can have myocarditis or carditis. They can have GI symptoms. Basically, think of the symptoms in the specific organs that we already talked about, where the virus was replicating, and I'll show you in the next in the next slide. Then we have a phase of recovery that's from day 14 onwards. It can last even beyond day 28, but this is the phase of recovery. And for patients who go beyond the peak phase, then they're likely to go into the recovery phase. So this is just a summarized schema illustrating the phases of infection. Related to the phases of infection, again, we have the immune responses that have been characterized from studies following survivors and even patients who were infected with Ebola and Sudan virus infection. So this is just a schematic looking at the evolution and the immune responses that characterize the different phases. So we have different time intervals. You have local replication that we talked about, mainly in the macrophages and the dendritic cells and the regional lymph nodes. Then you have systemic infection, which we talked about, the viral progeny that's going to the different organs. And then we have viral persistence, and we'll talk about the clinical significance of viral persistence in different organs. So basically, when you have the local replication, the first immune response you get is it's thought to be the innate immune response, which is non-specific, really related to the neutrophils and natural killer cells, and basically the host immune mechanisms that respond to an infection in the acute setting, but it's non-specific. So when this is ongoing, the viral load, the virus is able to establish infection, and you have a rapid viremia or development of viremia because of the local replication, as well as even the organ replication within the various organs. And then by around day 2, peaking at day 7, you now have the onset of the adaptive immune response, and you start forming IgM antibodies that are targeted against the Ebola virus, because we know that IgM is the primary immune, like as part of the adaptive immune system, is the one that kicks in earlier. Then you have also cellular immune responses that are part of the adaptive immune response. And then by around day 3, all the way peaking at around maybe day 20, then you have development of IgG antibodies. So IgM peaks around day 7 to day 10, and then your IgG is a few weeks later. But what is of note is that you have this high-level viremia that really corresponds to a lot of the clinical manifestation and even the clinical symptoms. So the observed death can occur anywhere between day 4 and day 16. And we talked about by the time your patient is reaching day 14, then they are probably on their way to recovery phase. And then you can have the post-sequelae symptoms, and we'll talk about this towards the end, because some patients actually have persistent symptoms, and studies have actually shown that the virus persists in some of these areas to explain some of these sequelae, which were described as particularly in the West African outbreak, because now there was a large pool of survivors. So this is a more detailed schema, just explaining the different phases. So we have the early phase, and we talked about non-specific signs: fever, general malaise, which is asthenia, anorexia, myalgia, and headache. So these symptoms are really non-specific, and they can sound like even the symptoms of conditions like malaria that we have commonly within our setting. Then around day 2, day 3, day 4, all the way to around maybe day 14, you have GI symptoms where a patient presents with nausea, vomiting, diarrhea, abdominal pain. And what you have to remember, these symptoms actually overlap. So they are not, it's not that one person will only have GI symptoms. They can have GI symptoms and then also develop a skin rash, which is described as maculopapular rash. Then the bleeding manifestations can begin anywhere around day 5 onwards, all the way up to day 21. So in the peak phase, this is where you have target like specific organ damage that you'd be looking out for, but you don't want your patient to be presenting. So when you have an outbreak, you want to identify cases earlier before they reach the peak phase, because when they reach the peak phase, they may require sophisticated management. So some of the manifestations in the peak phase include kidney failure, respiratory failure, neurological manifestations, heart failure, myocarditis, and pericarditis. but you want to identify your cases early. And that's why, particularly even in the Uganda outbreak, they're able to list the contacts, and we know that cases actually arise from contact. So they're able to monitor them. And once the contacts present with symptoms, including these non-specific symptoms, which fever is the commonest, then they're admitted to the Ebola treatment unit, and they're observed, and the standard of care is initiated so that you can optimize the outcomes of this patient. When your patient reaches day 21 onwards, then they are on their recovery phase. And one of the complications that persists or develops thereafter is uveitis, which is inflammation of the uveal tract within the eye. And this can be debilitating for the patients, but you'll also see some of the other chronic sequelae that have been described in some of the cases. So this is a schema for all of you who maybe are already overwhelmed by the great detail we've been talking about. The things to remember for your first phase is there are these non-specific symptoms: headache, fever, sore throat, extreme weakness, and aching of muscles. And then in the second phase, now you have organ-specific complications. So they can have nose bleeding, internal or external bleeding, impaired liver function. They can have the maculopapular rash. They can have the vomiting, impaired kidney function, and diarrhea. And then they go through the phase of recovery. Also important is really to track the laboratory or to anticipate some of the laboratory abnormalities that would occur. So one of the challenges is that when you have the cases in the setting of an active outbreak, it may not be easy to be able to send a lab sample to the general lab to analyze for some of these. So in some of the settings, they have dedicated labs where the diagnosis is made, and even where some of these tests can be done, because we know that the fluids from the patient are fairly infectious. So that will be one of the considerations. How will we balance caring for the patient and doing some of these lab tests, at the same time being able to keep the lab personnel safe, even in the setting of an outbreak? So one of the ways of doing this is really to have point of care laboratory equipment that can be placed within the Ebola treatment units that can be able to analyze some of these components, of to use point of care diagnostic devices that can be able to run some of these tests. So in the early phase, what we expect is a lymphopenia, a reduction in the white cell count. There'll also be a reduction in the platelet count as a reaction to the infection. And then in terms of your liver enzymes, there would be an elevation of the transaminases, both the alanine aminotransferase and aspartate aminotransferases. And this markers, the ALT is more specific for liver dysfunction, but we know that the AST can be elevated because of even involvement of the skeletal muscles, which are infected in the replication, because the virus is able even to replicate within those cells. Patients are likely to also have hypoglycemia. So we need to anticipate this and be able to correct. So part of the clinical management, as we shall hear from tomorrow, will be really to address some of these complications that are likely to cause death of the patient. So anticipating hypoglycemia and responding, and this occurs in the early phase. During the peak phase, you now have a reversal. You have elevation of the white blood cell count, particularly the polymorphonuclear cells, the white blood, the neutrophils. You have a reduction in the hemoglobin and a reduction in the hematocrit. And then you have kidney failure that will be characterized by elevation of the urea and creatinine. You have other electrolyte disorders like hyponatremia, or you can have hypo or hyperkalemia. You can have hypomagnesemia and hypocalcemia. So you have to anticipate these electrolyte disorders, and you resuscitate your patients and correct them appropriately. Your patients can progress on to metabolic acidosis, and this is characterized by increased lactate with reduction in bicarbonate. There'll be elevation of creatinine phosphokinase and myoglobinuria because of damage to the muscle. The patient is also likely to develop hypoalbuminemia, and then they'd have coagulopathy characterized by increased prothrombin time test, and D-dimer test. So you need to anticipate this and respond to it. And these patients who have coagulopathy would manifest with bleeding, and therefore they need replacement with whole blood. And some of these coagulation factors. So giving them plasma, fresh frozen plasma would be one of the ways of responding to this. So in the recovery phase, your patient's platelets would now start improving or correcting. So these are the clinical components. We may not be able to do a lot of these tests, but we know that in the optimized standard of care protocol that we'll share with all of you, we've actually, all these components have been addressed, and it gives a guidance in terms of what to do in the Ebola treatment unit to be able to anticipate and respond to each of these components to optimize the care of the patient and improve survival. So what are the differential diagnoses? We have a number of conditions that would be differential diagnosis. Some of these conditions, we don't really have them in our setting, like the Lassa fever, but we know that these outbreaks occur in a lot of sub-Saharan Africa, and Lassa fever is endemic to West Africa. So it's an important differential diagnosis. So in our setting, malaria is an important differential because it would have the fever and headache. We have typhoid fever again, yellow fever as a differential diagnosis. And I know we've had recently an outbreak in Isiolo. So it's important to always consider this. And then dengue is an important differential in our part of the world. And then brucellosis, leptospirosis, disseminated intravascular coagulopathy, which can be caused by so many other things, including even pancreatitis. Thrombocytopenic purpura, again, an important differential diagnosis because it manifests with petechial hemorrhages on the skin, and then tick-borne diseases, including tick-borne relapsing fever. So the list is very long. And what this means to us is that because at the point when we meet the patient, we need to entertain the possibility that they may be having any of these conditions. Where we're not able to investigate, the optimized standard of care allows us to provide an empirical treatment for the patient to be able to cover the most likely differential diagnosis in our patients, so that we are not losing the patients to treatable conditions like malaria, as we hold them in the as suspects for Ebola virus disease. So it's really, really important for us as clinicians to think of what else the patient could be having, because we know that even when the West African outbreak occurred in 2013 to 2016, some patients died due to some of these other conditions that could have been treated as the outbreak, as clinicians were busy battling the outbreak. So just to remember the list of differential diagnosis to be able to investigate for them or provide an empirical treatment regimen. So we have diagnostic tests that are able to make a diagnosis, and my slide is just one slide because I know we'll have a whole session talking about laboratory diagnosis, how to collect the samples in patients who meet the case definition, where to send the samples, how to package the samples safely. So I have this just one summarized slide. So early diagnosis can be very difficult, especially when you are not thinking about it, because particularly in Kenya, we've not, thanks be to God, we've not had a case. But in our setting, even making that early diagnosis may not be very, very easy. And this is because signs and symptoms are similar to the other infections that I've already told you about. There are laboratory tests that should be done, and the PCR detection is one of those. And then there are also ELISA assays, but the lab team will clarify more about this when they make their presentation. What is important to remember, these tests have to be done in biosafety level 3 or 4 labs, and therefore it means not all the labs will be able to make this diagnosis because it would put the lab healthcare workers at risk. So the current recommended labs, and this we'll hear more about from the lab team, is centralized lab testing in Cambridge, and mainly the Cambridge affiliated labs, and we'll hear more about this when they make their presentation. In terms of treatment, like I've said, we don't currently have curative treatment available for Sudan virus. For Ebola virus, there have been therapeutics that have been effective, but they've not been found, they have not been tried for Sudan Ebola virus. So currently, we don't have curative treatment. What we only have is supportive treatment. And like I've said, understanding the pathology really helps us to even know on which day the illness of the patient is likely to be, the phase of illness, whether it's early phase or second phase. And then we have to anticipate the complications that the patient is having and even complicating infections because they can have super infection. We need to ensure they have balanced fluid and electrolytes, and we've seen how the electrolytes are likely to be affected. We need to maintain the oxygen status, maintain the blood pressure and circulation, maintain the nutritional needs, manage any pain, and then treat the fever. So these are some of the things that we'll be hearing from the presenter tomorrow when we look at case management. For patients who survive and go through the recovery phase, we now know that they can be clinical sequelae, and there have been a lot of studies try to explain some of the explanation for this sequelae, but it's not unique because we know even for COVID-19, some of the survivors are being characterized to what is called the long COVID. So for Ebola, again, we have sequelae, and this is a very busy diagram. We have general manifestations like fatigue, weight gain, anemia. We have mental health issues, and that's why the mental health and psychosocial team will be talking to us more at length. And then we have central or peripheral nervous system manifestations, and particularly meningoencephalitis. Sorry. We have cardiovascular manifestations, urinary sequelae, urinary tract sequelae. We have involvement of the reproductive system, and some of the things that have been described include impotence and decreased libido and orchitis in the male. And then for females, again, decreased libido, amenorrhea, abnormal odor, and abnormal vaginal bleeding. In the eyes, we've had cases of uveitis, which leads to loss of vision and diplopia. Some patients have developed cataract, sensitivity to light, among others. And then in the ENT, again, tinnitus, throat pain, respiratory system. Some patients have had persistent shortness of breath, GI manifestations again, skin, including alopecia, and then musculoskeletal. So the list is very, very long. We really need to anticipate this in some of the patients, and it's important to follow up survivors for a fairly long period of time to see and manage some of these sequelae that they have. So some of these sequelae, particularly meningoencephalitis and uveitis, have been linked to persistence of the Ebola virus in the eye and in the brain. And this is thought to be because of inflammation, because as a response to the persistence of the virus. So this is just the explanation for that. So what is currently known is that this virus is able to cross to what we call privileged sites. And this include the blood-brain barrier. It's able to cross the blood-brain barrier and be able to affect the microglial cells and live within the microglial cells within the brain. In the eye, it's actually been able to, it's been obtained from aqueous humor within the eye. And in some studies, they've actually found it even within the anterior chamber and within the vitreous chamber in the eyes. And that explains the manifestations of uveitis, which is basically inflammation of the uveal tract. The involvement of the testis is able to cross the blood-testis barrier. It's able to go into the testis, but the long-term effect of that has not really been elucidated in terms of inflammation. But what is currently known is that the cell that is involved with the Sertoli cell within the testis, and as a consequence of that, it's actually able to be transmitted through semen to a partner. So some of the survivors, and there have been some small outbreaks, particularly in West Africa, that have been associated with resurgence of disease because of survivors who are harboring the infection within the testis. So we'll hear from the risk communication and community engagement team in terms of what is the guidance for people who are likely to survive in terms of the precautions they have to take to avoid infecting their sexual partner for a defined period of time. So that's really the basis of that you can have sexual transmission in someone who's convalescing and recovering from the infection. So this is a very summarized slide, and I know we'll be talking more about this when we have the infection prevention. But just in general, Ebola can be prevented through early identification and prompt referral and isolation of suspected cases. also by adhering to basic universal precautions of hand hygiene and gloving in health setup, wearing personal protective equipment when handling cases of suspects, and we'll hear more about what PPE and how to don and doff the PPE, because some of these processes, particularly doffing, is a high risk process, and we all need to be familiar with how to doff the PPE. Then avoiding contact with body fluids of suspected cases, handling appropriately and immediately burying bodies of Ebola victims, and then avoiding bushmeat and vaccines have been useful, but more only for Ebola. The evidence we have is currently just for Ebola. The importance of avoiding bushmeat is that we talked about the animal that is the initial would cause the initial infection in the index person, but you would know how many animals are actually infected when you have an outbreak. So really avoiding bushmeat means you're avoiding much more introduction into the community from people who get infected when they go out to hunt. So this is really an important component. And particularly even in our setup, I think this is one thing we need to study more, because we've described the Bombali Ebola virus within the bats in Kenya, particularly in the coastal area. What will be the significance of that? We currently know that we don't have cases of Bombali Ebola virus, but this is really something to watch out for, that we should not be going to the history being the first ones to have an outbreak of Bombali Ebola virus. So bushmeat should be avoided in the setting of an outbreak or even in general. And then intervention strategies, and we've seen some of this deployed as part of even our preparation. So supporting cases in care units and isolation, and the aim of this is to reduce transmission, to control the outbreak and reduce mortality and suffering of patients. And what we currently know is that early care of people in Ebola treatment units actually has an impact and prevents mortality and improves survival. So this is the messaging we need to pass to the community, so that even when we have cases within our country, identification of those cases and early referral to the Ebola treatment unit is not really to punish the person, but to have them be looked after and to anticipate the complications that we've already talked about. And then monitoring and tracking and tracing of contacts. So this is important to list all the contacts and trace them, so that identification of transmission chains and follow-up of possible new cases. That is the main aim of that. And then public awareness campaign that is currently even ongoing. So these are just some photos, just illustrating different things about the setup. So this is an Ebola isolation ward. This is the doffing area. Then you have the ambulance to carry the suspected, the cases from the community. This is a safe burial that's being undertaken by a safe burial team, and then care of patients within the Ebola treatment. These are photos courtesy of MSF in their previous outbreaks that they've cared for. And then this is alert checking, when there's an alert in the community, how to respond and try to take the history and find out if the person meets the case definition. And then clinical care and nursing, health promotion and campaigns, and then again, decontamination of houses. When you evacuate suspected cases, then you need to do decontamination of the houses. And we'll hear more about this from the WASH team, the water and sanitation and hygiene team, in terms of where we are in terms of this. So I think this is really my second last slide. So just to summarize, we have looked at the historical context. We've looked at the viral structure, clinical presentation, pathogenesis. And like I said, this lecture is to set the tone for subsequent presentations that we'll be having as part of this series. So what we know is that since its discovery in 1976, we've had more than 20 Ebola outbreaks in numerous countries. We've looked at the mode of transmission, and we know that it's not yet fully understood, but it's believed that the reservoir host is the fruit bat. Humans are contagious only when symptomatic. Let me repeat that. Humans are contagious only when symptomatic, and it's really important to keep these symptomatic people within the Ebola treatment unit early, because that early admission can improve the outcome. If left untreated, the disease develops into complications, including organ failure. As standard of care differ according to resources available, mortality also increases considerably. But we know that if we're able to provide people with an optimized standard of care, then we can improve the survival. Enormous changes, including innovations in management, have raised current management to higher standards, even in low resource countries. And we'll be hearing more about some of these interventions and innovations. So this is my last slide, and thank you very much. Over to you, Amina.
Okay. Thank you very much, Dr. for that very elaborate information. It's a very good overview and introduction. I believe most of us have understood. So there are a few questions, but let me start because I have the advantage of being the moderator. Is it the Sudan virus which is going on, the outbreak in Uganda, or is it the Zaire one? And if so, would a history of Sudan, it ended in Sudan? There is no Ebola at the moment in Sudan.
So thank you, Amina, for that question. So there are two outbreaks that are currently happening. We have an outbreak in DRC, or there has been a recent outbreak in DRC, and then now we have the outbreak in Uganda. So when you have an outbreak, it's really, really important to type the species that's responsible for the outbreak. So the current Uganda outbreak is actually caused by Sudan Ebola virus. We don't have an outbreak in Sudan. We haven't had an outbreak in Sudan in the recent past. So the current outbreak in Uganda is caused by Sudan Ebola virus, which is abbreviated as SUDV, SUD. The recent DRC outbreak has been caused by Zaire Ebola virus, which is abbreviated as EBOV. So the two viral species are very distinct. And the importance of even typing is that we know that the response strategies that you can use for EBOV, you can deploy ring vaccination, and you can deploy existing monoclonal antibodies, which are actually approved by FDA, but they are only useful for EBOV, which is caused by Zaire Ebola virus. They have not been used. They have not been tried in clinical trials for Sudan Ebola virus. And currently, we don't have enough evidence that they work. So just to clarify, we don't have an outbreak in Sudan. The Sudan Ebola virus that's causing an outbreak is currently in Uganda.
Okay, thank you. It was interesting how the case presentation in Kenya, we just asked about Zaire and recent history of travel to Uganda, and they have the Sudan vaccine, and we don't ask about Sudan travel. So I just wanted us to demystify that and clarify on that. So so even the vaccine would not, there's not enough clinical evidence on the vaccine working on the current outbreak in Uganda, correct?
Yes, we don't have enough evidence that the vaccine will work, because the way the vaccines, we have two vaccines. I don't want to preempt it because there'll be a presentation tomorrow.
Okay.
But we have two vaccines, one by Merck and one by J&J. The Merck vaccine is given as a 1 dose. The J&J vaccine is given as 2 doses with 56 days in between. So it's not appropriate for an outbreak response. The Merck vaccine has been designed to be a post-exposure vaccine. So you'd vaccinate people who've been in contact of a confirmed case. So you use a strategy that's called ring vaccination. You list all the contacts and then you vaccinate them, and it's able to work and produce antibodies that are able to protect the people from development of clinical disease. So it's been actually designed to be an outbreak response vaccine. However, in its design, it's only useful against Zaire. But I think in the planned clinical trials in Uganda, they will be testing a vaccine that is designed against Sudan Ebola virus that works perhaps through the same mechanism. But the current existing vaccines, none of them have been tried against Sudan Ebola virus. Even the existing monoclonal antibodies, none of them have been tested against the Sudan Ebola virus. So as it is, we don't have any therapeutics or vaccines.
Okay. So now, the great presentation. A lot of people have commented the presentation, and someone is asking if someone is someone infectious during the incubation period while asymptomatic. I know you've made it clear, but it's still a question. So,
what is the question, Amina?
Is someone infectious? Sorry, is someone infectious during the incubation period while asymptomatic? I think I have the answer.
Answered the question at the end.
Yes, yeah. yes, you clarified that question, but since it's open, I said, let me just go ahead. Second question is, what exactly is the cause of the bleedings during Ebola manifestation?
Okay, so I'll take the two questions. So people who are infectious are the ones who have symptoms. People are only infectious when they develop the symptoms. So during the incubation period, if they are asymptomatic, they are not infectious. So once they develop the onset of symptoms, then they are infectious. The second question is around the cause of the bleeding in patients who have Ebola virus disease. So it's a terminal event where you have many things happening. You have leakage of the damage to the endothelium that causes easy bleeding, easy bruising. You also have disseminated intravascular coagulopathy where there is increased prothrombin time, reduced platelets. All those things cause the person to start bleeding from, and it's spontaneous bleeding from different orifices. So it's not because of trauma. They start bleeding because of the coagulopathy that they have.
Okay. And someone asked in the same line of thought, I haven't seen in the management of the use of anti-bleeding drugs like tranexamic acid. Is it important in the management of Ebola?
So the mechanism of the bleeding in Ebola is because of the impairment of the coagulation pathway. And it's not directly because of problems with stabilization of the fibrin. So tranexamic acid is one of those drugs that is able to stabilize fibrin, and therefore its role would be in that stabilization. But in the bleeding in Ebola is because of a generalized coagulopathy. So just giving tranexamic acid alone will not have an impact. But what is more important is to try and replenish the coagulation factors that have been consumed. So it's a consumptive coagulopathy. So you need to replenish the coagulation factors, and therefore giving fresh frozen plasma would be useful. Transfusing fresh blood would be also another important mechanism, so that you're replenishing the factors that have been lost or have been consumed in that coagulopathy. So it's a different kind of mechanism for the bleeding that cannot be addressed only by tranexamic acid.
Okay. Another question is if somebody has been exposed to Ebola virus, does it confer to any form of immunity, whether lifelong or short?
Oh, so that's a very good question. In terms of durability of the immunity in survivors. So like I showed in the graph, we had different forms of immune responses. We had the IgM and then subsequently thereafter IgG, and a lot of studies during the West African outbreak were done to try and explain and perhaps even identify if there can be a role for convalescent plasma, which is plasma in people who have recovered, and whether it can be used because of presence of the antibodies. So the studies were a bit conflictive, non-conclusive. So in terms of durability of the protection in the person who's recovered, I'm not very certain that we have that. And I can probably look it up, and maybe tomorrow when we have the session, I can chip in tomorrow after I've done additional research. But what I even know, even for the current vaccines that have been developed for Zaire Ebola virus, the durability of the responses and even the dosing interval, if someone needs a booster, is not yet still very known. So this is science that is evolving, but I ask for additional time, then I can see if the people who've recovered are totally protected and cannot get infected with subsequent, and whether we currently know the durability, if any, of that response. So allow me to look further, and I'll provide a more definitive answer tomorrow around that.
Thank you, Daktari. I will definitely remind you to share that input. Pamela is asking, with the current AMR fear, how safe are we in terms of treatment, especially taking the COVID period into consideration, where antibiotics were prescribed at will? What can be done, or what will be done to such non-specific treatments that may be available in the hospitals?
So this is an excellent question, Pamela, about linking or protecting our antibiotics in the setting of increasing AMR, and at the same time providing patients a safety net where we cannot fully work up the patients. Like I've said, the challenges with availability of even culture, blood culture facilities within the Ebola treatment units. So the good thing is that we know that patients who are symptomatic should be managed in dedicated facilities, and these are called Ebola treatment units, and they are currently being established in the different counties to manage the patients. So we do not foresee a situation where people will be self-medicating with antibiotics or lack of judicious use of antibiotics at a wide scale. So in the guidelines that I showed a picture of the optimized standard care, we have taken that into consideration, and in the guideline, it clearly stipulates in which patient you should start an antibiotic, and even goes further to provide a guidance of which antibiotics, how to dose it, and for how long to dose it, as you try to work up the patient to exclude other differential diagnoses. Like we said, of the list of differential diagnoses that we had, some of those illnesses were viral illnesses, but we had a few bacterial illnesses, particularly things like typhoid fever. So we've made a provision for selection of antibiotics that are likely to cover the conditions that are in the list of empirical treatment, particularly the bacterial infections there. And these are antibiotics that are prescribed are actually intravenous antibiotics to be used in the Ebola treatment unit. So we are cautious of that fact, and we are providing that guidance. And as part of even antimicrobial stewardship is that part of the stewardship is that you once you start the antibiotic, you're defining the dosing, the indication, and the duration of that empirical treatment for that particular patient. So we are not giving an umbrella for people to use any antibiotic for a prolonged period of time, but we provided a guidance, and you'll be able to see this once you receive the guidelines.
Okay. Thank you very much, Daktari. Another question is, what's the explanation for the raised white blood cell count in the latter part of the illness? Like it drops and then it goes up. What's the explanation?
So what is currently thought to explain the initial lymphopenia and then subsequent lymphocytosis is that for most of the viral infection, that's a trend that is observed, that initially you have suppression, the cytokines that are produced cause a suppression of the white cell response, and you have reduction in the white cell counts, and then subsequently you have an increase. So sometimes the increase in the later part of the illness can actually be a response to an infection. You can have a super added infection, or you can just have a normalization or the reversal of the different cytokines that now mediate production of the white blood cell count. So it's a phenomenon that's described in several viral infections, where initially you have suppression of the white blood cell production, and then subsequently, as some of the complications set in, then you have neutrophilia, particularly increase in the neutrophil cell count that now characterizes that elevation. So one of the things you have to be on the lookout is to try and identify if the patient is having a super infection that can explain that, and by appropriately covering empirically, or in settings where you might have the blood culture machine to be able to obtain samples for blood cultures to investigate the patient. So the initial response is cytokine suppression, and then thereafter can be infections or complications.
Okay. Salim is asking if you could shed more light to why is it that the male counterparts die if they're infected with Ebola more frequently than the female. Is there a specific reason to that?
So I'm not sure what explains the increased mortality, but you're very right. In cases where you have Ebola outbreaks, the outcomes of the male patients are worse. So particularly for Ebola virus disease, some of the adverse risk factors for mortality include things like pregnancy, being of male gender, extremes of age. So the very young children, the very elderly people, but it's of note that the men are at increased risk of mortality. I'm not sure the main explanation for that, but may just be some biological difference. So allow me to look up additional information around that, and I'll provide a more definitive answer tomorrow. But it's an observation, just like even we saw even in COVID-19. So there might be a more biological rationale for the increased fatality among the male patients. So allow me to check more information around that.
Yeah. Thank you. So a couple of more questions based on what are the strategies Kenya is deploying to prevent Ebola from entering from the borders like Busia. You've mentioned setting up centers to manage Ebola, but what more is the government or the Ministry of Health doing to prevent the spread from Uganda to Kenya?
So in terms of the preparation to prevent the spread from Uganda to Kenya, the Port Health and Border Control Units, particularly at Busia and Malaba border, have been on heightened alert since the outbreak began, and the ministry with its partners has worked fairly hard to be able to screen travelers going both ways, like from Uganda going from Uganda coming to Kenya, and even people who cross along there. But what we know is that there are lots of porous borders. So one of the additional strategies has been to use community-based surveillance system, where the community health volunteers and other community health workers are being sensitized and trained to be able to identify and notify in cases where there are alerts. So there's been surveillance where temperature checks have been reintroduced in those particular areas to be able to identify people who are crossing from Uganda to Kenya. Additional measures are not only confined to Busia, but have also been done for travelers arriving by air or even travelers coming from neighboring countries. So remember, the cases can move from Uganda to neighboring countries and come. So all the border posts have been screening people who are returning, particularly using temperature screening as part of that. But allow me to defer this, because I know there will be a presentation about the epidemiological surveillance that will cover more on this of what has been done so far in terms of trying to protect for people who are returning and crossing the borders. But a lot of strategies have been put in place to educate people, even to identify potential cases. And that's why for some of you who've been listening in the media, there've been alerts that have had to be investigated, and all the investigations have turned out to be negative after even some cases even met the threshold and were tested, but they came back negative. So there's been a lot of things that have been happening and continue to happen until the cases in Uganda, we hear that the outbreak has been declared to be finished.
Okay. Regarding transmission, is it transmittable from mother to child through breast milk? Nyawira is asking.
Yes. So one of the body secretions where Ebola virus can be transmitted is through breast milk. So yes, the answer to that is yes. And it can be transmitted through breast milk. And one of the documents that we actually even have is to try and see. So when you have a mother that is infected and they have a small baby, then you have to really rationalize and see whether you separate the mother or the child. And remember, because also of the close contact, it may be the breast milk or other secretions that can still cause the infection. So in some of the cases and some of the situations, you'd have to weigh and be able to still allow the mother to breastfeed, particularly if the child is young, because they need the mother's nutrition, and therefore you could address the outcome of that case on an individual basis. But to answer the question in summary, yes, body fluids can transmit, and one of such body fluids includes even breast milk.
Okay. So we have a question from John, and Dr. just to clarify, it's regarding the burial part. So if I'm not, correct me if I'm not wrong, we are having a session on this that can cover the topic on burial.
Yes, yes. So that will be covered very well when we talk about the safe and dignified burials.
Yeah. There's still a question on transmission. Probably it's not very clear. Member is asking, Eric is asking, can one get infected with Ebola through saliva contact?
The answer is yes. Someone can get infected through saliva contact because once someone is symptomatic, their body secretion can infect you. So we talked about mucous membrane, and the infection through saliva is very direct because once the saliva comes into contact, for example, if it's through the process of kissing, it will just penetrate the mucous membranes in the mouth and you can have an infection. So saliva is another body secretion that can transmit Ebola virus. So just to summarize, Ebola in a person who is infected and symptomatic will be in body secretions that they produce, including breast milk, including semen, including saliva, including even sweat.
Yeah, so I can see the topic of transmission is generating more questions on transmission. Now we're having question on semen. Can semen cause a new outbreak?
We talked about that. We talked about semen causing a new outbreak.
Yeah.
I even emphasized when I was talking about the structure of the testes and the Sertoli cells. Yes. Semen can cause a new outbreak. And in people who've recovered, we'll hear from the risk communication team about how to protect themselves and really to abstain from sex or use condoms in that convalescence period. And we'll hear more about this from the risk communication and community engagement team. So because I know this audience is largely healthcare workers, whatever we've talked about this audience applies to the general population. So even the people who've recovered in the general community are likely to be infectious and should have that information that they can perpetrate or they can infect their sexual partners through semen, through the semen, yes.
Okay. So Dr. in the interest of time, we can probably close the session with a parting shot. Tomorrow we'll have a discussion on case management and therapeutics of Ebola virus disease. So Dr. Maritim, what would you like the team to talk about?
Oh, in tomorrow's session. So
no,
we'll
I mean,
hear, sorry, Amina, sorry, say come again.
It's just a summary of the introduction and overview. What's your parting shot?
Oh, so as we come to the end of this session, I think my parting shot is to just remember that Ebola virus is very, very contagious. It's very infectious. We know the clinical manifestations. We know the modes of transmission, and we need to educate maybe the people we work with who are not able to attend this webinar, just to disseminate what we've learned today. And I want to encourage people, because this is a whole series of webinars, to be able to log in and listen to the complete sessions that we'll have, so that they can be able to have enough knowledge to empower themselves to be able to detect, manage, respond, prevent, to mitigate any outbreak or cases that we may have. So just to attend the session, ask questions. For questions we are not able to answer immediately, we'll have different opportunities as the sessions are going on to be able to get back to you with the answers that you need to, for questions that you've asked us. So thank you very much for your patience and for your very interesting questions. Thank you.
Thank you. Thank you. Thank you very much, Dr. for your very elaborative and very informative discussion on the introduction and overview of Ebola. And thank you, listeners, for listening. I hope I see you tomorrow for the case management and therapeutics of Ebola virus disease. Thank you, people. Bye-bye.
Thank you, everybody. Thank you, Amina. Bye-bye.